Assalamu alaikum. Inshallah, today we will talk about Achilles tendon rupture. Simple topic, I hope. Tendo Achilles is formed by soleus and gastrocnemius. They are both in the superficial compartment of the leg, superficial posterior compartment of the leg. We have 4 compartments in the leg. 2 of them are in the posterior compartment. The superficial one holds the Achilles tendon, which is formed by soleus muscle anteriorly and gastrocnemius posteriorly. This is the plantaris, coming from lateral femoral condyle and passes medially. The insertion of the Achilles tendon to the posterior calcaneus, as I inform you, soleus and gastrocnemius. Soleus switch its movement from the anterior part to the medial side of the Achilles tendon. So the gastrocnemius tendon inserted in the posterior calcaneus laterally and soleus medially. And this spiral arrangement aim at when there is forces or loads on the muscle, the forces dissipate, the load dissipate by unfurrowing of this arrangement, by rearrangement of this arrangement. Okay. Sural nerve coming about this tendon, Achilles tendon, is about 10 centimeter from the insertion to the musculotendinous unit. And the sural nerve coming from the lateral side of the tendon, about 10 centimeter proximal to the tuberosity. So if I do MIS percutaneous procedure, it mostly will be injured at this level when I take a stitch here. So don't forget the spiral arrangement and its importance and the location of sural nerve. The tendon, its vascularity coming from the insertion, from the bone, and from the musculotendinous origin, and from the paratenon. Paratenon isn't like the sheath of the flexor and the extensor. The sheath for the flexor and the extensor has 2 layers, parietal and visceral. Paratenon, which cover the Achilles tendon and the patellar tendon, for example, has only 1 layer. And the synovium passes inside, giving also a nutrition for the tendon. So 3 sources at the insertion and at the musculotendinous part and from the paratenon. It could be injured here or there, or most commonly in the watershed area, about 2 to 6 centimeter from the insertion. I inform you that about the tendon length is 10 centimeter about. Its middle part is mostly injured because of its hypovascularity. This is the spiral arrangement and its importance. The blood supply coming from down and up and in the middle, the middle 2 to 6 centimeter is hypovascular area. Please, I inform you that paratendon is one of the vascularity, so please, when it is injured and you aim to repair, please repair it to increase the healing power than the powerful of the muscle. Pathogenesis. All tendons can be ruptured, traumatic or spontaneous. Spontaneous, I mean by spontaneous, it is ruptured because he has a significant pathology. For example, in old age, he is renal failure. He has a renal transplant and he is on a steroid or immunosuppressive therapy. This is a general rule for all tendons. Achilles tendon, quadriceps tendon, patellar tendon, the same. Okay, but traumatic event, either direct or indirect. Direct by direct sharp cut, or indirect by forcible contraction of the muscle. And this is called, but not a contraction. The contraction of any muscle could be concentric or eccentric. Concentric contraction means that the muscle decrease in length, contract to decrease in the length. Eccentric contraction means that the muscle contract while its length increase. In our real life, when you are going upstairs, you contract your quadriceps, so it contracts to shorten the length between its insertion and the origin, so it can extend your knee. When you are going downstairs, you still contract the quadriceps, but you are flexing the knee. So its length increase despite its contraction to make a controlled flexion of the knee to avoid your drop while you are going downstairs. So eccentric contraction of Achilles tendon, you are pushing off your foot to go for walking steps. You were talking about gait cycle later. At the push off phase, you are doing eccentric contraction of Achilles tendon to make a controlled forward deflection of your body, not to fall down forward. It contract your you contract your Achilles tendon to hold your body back when you are pushing off your foot, your body, to progress during your gait. So eccentric loading, eccentric contraction, sudden eccentric contraction of the muscle could tearing it, and this occurs in two types of people: sedentary life like me, and also sports athlete. As I inform you, it could mostly it is in the middle hypovascular region, 2 to 6 centimeter proximal to calcaneus. Please don't forget about the associated injuries. 25% of Achilles tendon is missed as an ankle sprain. It could be associated either by medial and calcaneal tuberosity, so X-ray is important. Again, in the older age with spontaneous rupture, it could have intratendinous degeneration, tendinosis, and could be in the traumatic event also. For all tendons, middle-aged men are more susceptible in the third to fourth decade is susceptible. Either sedentary people or athletic activity with wrong movement could be a cause. Spontaneous rupture, I tell you, eccentric contraction. What is the difference between eccentric and concentric? Eccentric is a progressive lengthening of the muscle despite of its contraction. Natural history. If you didn't treat Achilles tendon, it will affect his life, either conservative or operative. But he needs treatment. It wouldn't resolve spontaneously. As I inform you, about 25% of Achilles is missed as ankle sprain. He described, usually he is telling you that during the sports he found a painful or shooting pain. He can't bear weight because of his pain. When you examining him, you feel a palpable gap, and when you're doing a cuff squeeze test, when you are squeezing during a prone, when you are squeezing the superficial layer, superficial group of the posterior compartment of the leg, don't go too deeply as this picture. Please go be superficial, because plantar flexion can be done by other plantar flexors, secondary plantar flexors. Achilles tendon is the primary plantar flexor for the ankle, but there is secondary, for example, flexor, all the muscle coming behind the medial malleus, flexor hallucis and flexor digitorum. It could also aid in tibialis posterior, also can be aid in, can act as a secondary plantar flexor. So please squeeze up. If it is disconnected here, it won't plantar flex. Regarding X-ray imaging studies, you have to know that Achilles tendon is a clinical diagnosis. But sure, I will do X-ray AB and lateral to exclude other injuries, other bony injuries. There is also another sign, Kagger triangle. Kagger triangle is a fat band in the front of Achilles tendon. This is the density of Achilles tendon, and this triangle formed by the base of the calcaneus and the confluence of the Achilles tendon and the back of the talus and tibia. This is the triangle. If the Achilles tendon is cut or discontinued here, this triangle will disrupted. This is called Kagger triangle. Sure, ultrasound and MRI can aid if diagnosis and the history is inconsistent. If you couldn't judge about the your diagnosis, you can do ultrasound, but largely, as usual, it is an operator dependent, or go directly to MRI. As I informed you before, if you see fat white, it is T1. There is a white signal here, discontinuity here at its insertion of Achilles tendon. This is sure T2. Fat is suppressed, fat is black. There is discontinuity. Where is the continuity of Achilles tendon? This is sagittal T2 MRI. Differential, actually there is no actual differential diagnosis for Achilles tendon, but don't forget that it is messed with ankle sprain. Non-operative management. As a rule, there is no clear indication and advice between non-operative and operative management regarding all has advantage and disadvantage. So please discuss with the patient and inform him about the disadvantage and advantage of each modality, and let him judge. Let him choose between both. Also, your management is guided by the age of the patient and level of activity. Sure, if he has no comorbidities and he has no relative contraindication about wound infection like smoking, you can go for surgery. If he is a sedentary old man with a lot of comorbidities and diabetic patient and heavy smoker, you can go for conservative. You can give him an advice, but you will inform him about advantage and disadvantage of each modality and let your patient choose. Of course, if you give a non-operative management, you can at least 8 weeks of immobilization. Non-operative management, the main disadvantage that decrease the strength compared to operative and increase the rupture rate, because the gaps isn't opposed to each other with non-operative. Even when you are doing plantar flexion equinus of your ankle, it still there is a gap. So the incidence of re-rupture and the incidence of decreased strength is increased to non-operative. So with operative, both complication, the re-rupture rate decrease and the strength increase, but there is a wound surgical complication with surgical management. In non-operative management, there is no wound. Wound adhesions and adhesions is the major motivating factor which makes the surgeon go to non-operative management. Okay, we can advise elderly patients with limited functional expectation, significant tobacco use, chronic cortisone treatment, or has a vascular comorbidities, renal failure, could be a real and judgeable indications for non-operative management. Again, you will discuss with the patient and inform him and let him choose. Surgical management, as I tell you, the advantage, functional outcome and strength, lower rupture rate is better than non-operative management. As I tell you, the most part injured is 2 to 6 centimeters in the hypovascular area. You are doing repair usually for this area, but if at the insertion you should use anchor to insert the tendon, and if the musculotendinous, you can go for conservative management. Again, how can I do the repair? The repair either traditionally open or percutaneous, limited open, or open with augmentation. Open repair is the most powerful one regarding strength, but has a wound complication. Other methods, percutaneous and limited open, to decrease the incidence of wound complication. This is the main. But the incidence of injury of that sural nerve, which coming about 10 centimeter from the lateral border, at the lateral border of the Achilles, from the insertion of the Achilles tendon, is increased. You didn't see the sural nerve. In open, you see everything. In percutaneous or limited open, the incidence increase of injury of the sural nerve. Open repair with augmentation, plus or minus augmentation. Mostly flexor hallucis longus if I use, or plantaris, which at the medial side. You have three types of incision, either medial or lateral or midline. Please don't do midline incision. Don't do. You are directly over the tendon, so prone to adhesion and irritation. Please go medial. Excellent exposure. You do a lateral flap. Be away from the sural nerve injury, and you can manage everything. Lateral is directly over the sural nerve, so please do medial or posteromedial. What is chronic tendo-Achilles rupture? Chronic tendo-Achilles rupture more than 2 months, about 2 months. The problem that there is a gapping. The problem that the muscle come to be pulled to approximate the edges. This is the problem. If you can approximate the edges, even if it is chronic, go for primary repair. Debride the edges and go for primary repair. But if the gap increase, you have to lengthen the proximal stump through, for example, VY advancement, and do a primary, plus or minus augmentation with flexor hallucis longus. Again, the operative details, just simple notes. Medial incision, please don't go for midline incision. Debride the edges. Don't go do aggressive debride. Don't do aggressive debridement to avoid gapping. Personally, I use AC Bond 5. A lot of people taking 2 or 3 non-absorbable suture, number 2 or 3 non-absorbable suture, but I feel comfortable with 5. It's heavy bulky suture and it's good for fixation. Don't forget to repair your paratenon because of to increase the vascularity. What is the advantage and disadvantage of conservative versus operative management is a classic real life and viva exam. So train your answer. How you will treat, I will discuss and inform the patient about disadvantage and advantage of each management protocol. They can give you a clinical picture of rupture tendo-Achilles and inform you about clinical, ask you about everything, clinical assessment and management protocol. What is the surgical options of chronic rupture, as I inform you. Percutaneous management is simple management. Just to try to avoid sural nerve injury, he did simple snaps like this, and he is starting from the lateral side, from the side of the sural nerve, and coming transversally, then crossed, then again like this. This is the draw. Then trying less complication rate, but the rupture rate is increased compared to classic open. Sural nerve injury is more. He can give you a viva, classic viva question like this. He give you a history or examination what is the diagnosis, risk factors, and management. I got a case since about 2 weeks. I examined him. He informed me that since 2 months, since 3 months, he get a trivial injury, and he about 25 years old. Trivial injury since about 3 months. Then everything was improving without management. Since 2 days, he feeling a bobbing injury while playing football, and severe pain. In the first scenario, since 3 months, he go to a hospital and they did a cast. He didn't feel comfortable with cast and remove it after 1 day. Then again re-injury and coming again. I examine him. I suspect Achilles tendon rupture. I do the ultrasound. He tell me that there is a gapping about 1 centimeter, and there is about hematoma about 3 centimeter. I prepare him for surgery and open him and shocked with this gap. This is the proximal stump and this is the distal stump. Just I show you this picture. If you feel any inconsistency regarding examination and history, go directly for MRI. Then I try to pull the proximal stump. As I inform you, one of the methods in the chronic, that you pull the proximal stump and try to relax the muscle. Try to relax the gastrosoleus complex. Still there is a gapping here. There is about 2 centimeter gapping. I did VY lengthening and closed it, hoping that it will heal well. Just informing that if there is inconsistency about the history, fake history, he is missed firstly as an ankle sprain. They did for him a cast. Then he didn't feel comfortable. He is struggling, but still the pain decreased. He do another try to play. He feeling a real pop. Just some fascicles could be healed and re-rupture. This was the real scenario intraoperative. Be prepared for chronic, and if any hesitation, present regarding history and the examination, do MRI to see detailed anatomy. Thank you so much.